Pleasant day to everyone. We shall be discussing the white blood disorders, and we will divide the topic into the non-neoplastic disorders and the neoplastic disorders. The white blood cell count are part of the peripheral blood, and they are usually distributed as follows. The white blood cells or leukocytes may be divided into two broad groups, the phagocytes and the lymphocytes. Phagocytes comprise cells of the innate immune system, whereas lymphocytes mediate adaptive immune response. The phagocytes can themselves be subdivided into granulocytes, which includes neutrophils, eosinophils, and basophils, as well as the monocytes. The granulocytes and monocytes have significant capability of phagocytosis. The neutrophils and the monocyte have common precursor cell, and they are mostly tissue cells, meaning to say from the bone marrow, they enter the peripheral blood transiently before entering the tissues. The monocyte is unique in the sense that when it enters a tissue, it becomes activated and becomes a highly specialized mature macrophages. Now, most of the neutrophils actually are found in the bone marrow. We will find several groups of granulocytes. So you have your pluripotent, your progenitor cells, the myeloblasts, the promyelocytes, the myelocytes, the metamyelocytes, and the segmented neutrophil. This serves as a storage pool for the granulocytes, and only about 10% are actually found in the blood. Some of them are freely circulating, while the rest are adherent or marginating in the endothelial cells. This picture shows you the stages of granulocytic maturation. Take note that you cannot distinguish the different types of granulocyte until they reach the stage of the myelocytic series, at which point they express granules that are characteristic for each type of granulocytes. The bone marrow dedicates most of its production to the granulocytes, so that the granulocyte to erythroid ratio could be anywhere from 2:1 to up to 12:1. Now, as the neutrophil matures, they express several types of granules. So during the early phase, they will express the primary granules, which are your asurophilic granules. That includes your myeloperoxidase. Once they reach the promyelocytic stage, then they start producing the secondary granules. And then at the level of the metamyelocytes, they start to express the tertiary granules. A long time ago, the expression of some of these granules were used to classify the different types of leukemia, but is now no longer used. All of the granulocytes are eventually derived from the pluripotent stem cell in the bone marrow that differentiate into a common myeloid and a common lymphoid progenitors. The ability of the stem cell to differentiate along the myeloid cell line is influenced by several cytokines. That includes your thrombopoietin, your granulocyte colony stimulating factor, your thrombopoietin, as well as interleukin 3 and interleukin 6. During times of infection, granulocyte production is increased by the effect of your endotoxin that stimulates the monocytes as well as the T lymphocytes to express the different cytokines that eventually stimulates more granulocyte production. Now, some of these growth factors and cytokines that we have mentioned are now available for therapeutic uses. And the most widely used of these is your granulocyte colony stimulating factor, which we know pharmaceutically as your filgrastim. So this is used in to treat neutropenia, post chemotherapy, radiotherapy, or during stem cell transplantation. They may also be used in myelodysplastic syndrome as well as in severe benign neutropenia. It is also used to mobilize your stem cell from the bone marrow to the peripheral blood, allowing it to be harvested and be used for stem cell transplantation. The monocytes, as we have mentioned, when they enter the cell, becomes highly specialized macrophages. And within each organ system, you have your characteristic macrophages. For example, within the kidney, you have your mesangial cells. In the brain, you have the microglial cells. In the liver, you have the Kupffer cells. You also have the osteoclasts in the bone marrow. The neutrophils function in three phases. So there is a stage of chemotaxis or cell mobilization and migration where the neutrophils is attracted to bacteria or the site of inflammation by chemotactic substances released from damaged cell. Where eventually they will find this foreign material, either bacteria or fungi or dead damaged tissues, and phagocytose them. Then the microorganisms are killed and digested by means of your oxygen-dependent and oxygen-independent pathway. Defects in your neutrophil function could be directly related to this normal function of your neutrophils and monocytes. So you could have defect in chemotaxis, phagocytosis, killing, and digestion. So defects in chemotaxis would include your so-called lazy leukocyte syndrome, which may be acquired or congenital. And usually these are secondary to deficiencies in your leukocyte adhesion molecule. Phagocytosis may arise because of a lack of opsonization, which may be caused by congenital or acquired causes of hypogammaglobulinemia or lack of complement component. Abnormality in killing is exemplified by the rare X-linked or autosomal recessive chronic granulomatous disease that results from abnormal leukocyte oxidative metabolism. There is an abnormality affecting different elements of the respiratory burst oxidase or its activating mechanism. The patients have recurring infection, usually bacterial, but sometimes fungal, which presents in infancy and early childhood. Other rare congenital abnormalities may result in defects of bacterial killing, for example, myeloperoxidase deficiency and the Shirak-Higashi syndrome. Benign disorders, on the other hand, are either inherited condition or acquired condition that affects the granulocyte morphology. So most of these are benign, such as your Pelger-Hewitt anomaly, wherein you have a bilobe neutrophils instead of the 3 to 5 lobe segmenters. Occasionally, unsegmented neutrophils are also seen. In some cases, you might have a Pelger-Hewitt-like anomaly, and this is seen in patients with myelodysplastic syndrome as well in occasional patients with acute myeloid leukemia. In May-Heglin anomaly, the neutrophil contains basophilic inclusion of RNA, resembling your Dole bodies. There is an associated mild thrombocytopenia with giant platelets. Inheritance is autosomal dominant and usually due to mutation in your MYH9 gene, which encodes a myosin heavy chain. Other rare disorders would include your more severe disease like your Shiyak-Higashi syndrome, which is inherited in an autosomal recessive manner. There are giant granules in the neutrophils, eosinophils, monocytes, and lymphocytes, accompanied by neutropenia, thrombocytopenia, and marked hepatosplenomegaly. More commonly, what we see are morphologic abnormalities shown in the picture. These are often associated with, let's say, megaloblastic anemia, hypersegmentation, or secondary to infection as in Dole bodies and toxic changes in infection. A drumstick bar body appear on the nucleus of a proportion of neutrophils in normal females and is caused by the presence of 2 X chromosomes. This is not illustrated. The more common types of benign white blood cell disorder are quantitative. So these are increase in the different white blood cells. The most common of which is neutropenia, where you have an increase in circulating neutrophils to level greater than 7.9 times 10 to the 9. It is one of the most frequently observed blood count changes. The causes of leukocytosis the neutrophil leukocytosis is sometimes accompanied by fever as a result of the release of leukocyte pyrogen. Other characteristic features of reactive neutropenia may include a shift to the left in the peripheral blood differential count, where you have an increase in the number of band forms, and the occasional presence of more primitive cells such as metamyelocytes and myelocyte. Sometimes this is accompanied by the presence of cytoplasmic toxic granulation and Dole bodies. You may also have leukemoid reaction, which is reactive, and excessive leukocytosis, usually characterized by immature cell. Associated disorders include severe or chronic infection, severe hemolysis, or metastatic cancer. Leukemoid reaction are often particularly marked in children. Erythroblastic reaction is characterized by the presence of erythroblasts and granulocyte precursor in the blood. It is due to metastatic infiltration of the marrow or certain benign or neoplastic disorder. Shown here is a leukoerythroblastic blood film, with a shift to the left and the presence of the nucleated RBC. Most cases of leukoerythroblastic blood films are infiltrative diseases of the bone marrow, although this may also be seen in severe hemolysis and severe megaloblastic anemia. Neutropenia is a decrease in your neutrophil count below the normal neutrophil count, usually around 1.5 times 10 to the 9. However, people of African and Middle Eastern descent may have a values lower than this. And this has been called benign ethnic neutropenia. When the absolute neutrophil count level falls below zero point 0.5 times 10 to the 9, the patient is likely to have recurrent infection. And when the count falls to less than 0.2%, the risks are very serious, particularly if there is a functional defect. Neutropenia may be selective or part of the general pancytopenia. It may also be acute or chronic, lasting more than 3 months. Causes of neutropenia are shown. The more common ones are usually drug-induced, especially by anti-thyroid drugs, anticonvulsant drugs, or it could be secondary to immune diseases, like for example SLE, Feltis syndrome, or hypersensitivity and anaphylaxis. And also, as mentioned, neutropenia may be part of a bone marrow failure or secondary to increased splenic sequestration. Severe neutropenia is particularly associated with infection of the mouth and throat. Painful and often intractable ulceration may occur at these sites on the skin or at the anus. Septicemia rapidly supervenes. Organism carried as commensals by normal individuals such as Staphylococcus epidermidis or gram-negative organisms in the bowel may become pathogens. Eosinophilia is defined as an increase in blood eosinophils above 0.4 times 10 to the 9. It is most frequently due to allergic diseases, parasites, skin diseases, or drugs. Sometimes no underlying cause is found and no clonal marker can be detected. If the eosinophil count is elevated above 1.5 times 10 to the 9, that's 1,500, for over 6 months and associated with tissue damage for which no other cause can be detected, then the hypereosinophilic syndrome is diagnosed. In the HES, the heart valves, central nervous system, skin, and lungs may be affected. Treatment is usually first with high-dose corticosteroids and second line with cytotoxic drugs, for example, imatinib, hydroxyurea, methotrexates, or immunosuppressant. An increase in basophil above 0.1% is uncommon. The usual cause is myeloproliferative disorders such as chronic myeloid leukemia or polycythemia. Reactive basophilia are sometimes seen in myxedema, during smallpox or chickenpox infection, and in ulcerative colitis. Other quantitative disorder of the white cell would include lymphocytosis, monocytosis. Let us now move on to the neoplastic diseases of the blood. Hematologic malignancies are clonal diseases that derive from a single cell in the marrow or peripheral lymphoid tissues that has undergone genetic alteration. This abnormal clone of cells gains a proliferative advantage over the normal stem cells, and eventually they expand with new cell line and overwhelm the normal hematopoietic tissues. Cancer statistics in the Philippines will show that leukemias are not really that common, although this may be secondary to underreporting. However, in males, the leukemias comprises 5% of the total malignancies. In this particular study, there is no distinction between the different types of leukemias. While in the female population, again, the leukemias are not really that common. Just like any malignancies, hematopoietic neoplasm may be associated with certain risk factors. This includes inherited factors, environmental factors, and certain infection. Certain inherited condition may predispose the patient to, or certain genetic condition may predispose the patient to certain hematologic malignancies. For example, acute myeloid leukemia in patients with Down syndrome, lymphoproliferative diseases in patients with disorder with inherited immune deficiency. For example, patient with Wiskott-Aldrich syndrome. More importantly, your hematologic neoplasm may be associated with certain environmental factors. The most important of these would be your exposure to benzene, drugs, especially the anti-cancer drugs, specifically the alkylating agent, or exposure to high doses of radiation. Now, certain types of infectious diseases have been associated with certain types of hematologic neoplasm. This includes your HTLV1, which is said to be the causative agent of your adult T-cell leukemia lymphoma, which is a rare form of malignancy commonly seen in ethnic groups in Japan and in the Caribbean areas. Epstein-Barr virus is associated with your Burkitt's and Hodgkin's lymphoma, as well as in your post-transplant lymphoproliferative diseases. Your herpes virus, on the other hand, has been associated with primary effusion lymphoma and Castleman disease, while your HIV is associated with high-grade B-cell lymphoma and often lymphoma arising in unusual site. Your H. pylori bacteria has been associated with your gastric lymphoma. In fact, patients with gastric lymphoma may be treated by simply eradicating your H. pylori. There is also an association between your malaria and your Burkitt's lymphoma. Now, malignant transformation occurs as a result of accumulation of genetic mutation in cellular genes, particularly your proto-oncogenes and your tumor suppressor genes. Sometimes the underlying defect are the tyrosine kinases. These enzymes phosphorylate protein on tyrosine residue, which is important as cell receptor and intracellular signaling. Mutation of them underlie a large number of hematologic malignancies. Now, proliferation of normal cell depends on a balance between the action of your proto-oncogene and your tumor suppressor genes. In a malignant cells, this balance is disturbed, leading to uncontrolled cell division. Okay, so when your proto-oncogene is disturbed, there is a gain in function, resulting in unregulated proliferation. While suppression of your or mutation of your tumor suppressor gene will lead to failure in apoptosis, causing excessive proliferation and accumulation of neoplastic cells. Now, these are some of the genetic abnormalities found in hematopoietic neoplasm. Take note, some of these genetic abnormality may be disease-defining. For example, the translocation 15 and 17 is diagnostic of acute promyelocytic leukemia. Your Philadelphia chromosome is diagnostic of chronic myeloid leukemia. Your deletion of chromosome 5 and 7 are particularly important in specific groups of myelodysplasia. Genetic abnormalities are also seen or common in the lymphoproliferative neoplasm. Now, the neoplastic diseases may be operationally classified into myeloid and lymphoid. And the behavior of the neoplastic cell is dependent on the degree of maturation that the abnormal cells could actually undergo. So based on the degree of maturation, we commonly divide the neoplastic blood cells, the neoplastic diseases of the blood, into chronic and acute, myeloid or lymphoid. So when it is an acute type, there is usually a maturation arrest so that the presentation is more of an acute leukemia. While if it is of the chronic type, there is usually an excess in mature cells. Okay? So you have your chronic leukemia. Now let us go over to the leukemias. The leukemias are a group of disorders characterized by accumulation of malignant blood cells in the bone marrow and the blood. And according to cell type, this may be myeloid or lymphoid. And according to cell maturation, it may be acute or chronic. So we could classify the acute leukemias or the leukemias as either acute myeloid or acute lymphoid leukemias, chronic myeloid or chronic lymphoid leukemias. The acute leukemias are seen in all ages. It has an explosive onset, usually sudden. And the primary cells are the immature cells. And because of this, bone marrow failure is quite significant. So patient will have anemia, thrombocytopenia, and absolute neutropenia, leading to signs and symptoms of anemia, bleeding, and predisposition to infection. Organomegaly is usually mild at the time of presentation. The chronic leukemias, on the other hand, are usually diseases of the adult. It has an insidious onset. Since most of the cells are mature cells, the bone marrow failure is generally mild. In acute leukemia, the white cell count is variable. It may be normal, low, or increase. But in chronic leukemia, the white cell count is invariably elevated. In addition, organomegaly is common in patients with chronic leukemia. But what differentiates acute leukemia from chronic is the total percentage of blast cells. Based on the WHO guideline, Acute leukemia is defined as the presence of over 20% blast cells in the blood or bone marrow at the time of clinical presentation. However, it can be diagnosed with even less than 20% blasts if specific leukemia-associated cytogenetic or molecular genetic abnormality are demonstrated. Epidemiologically, your AML is the predominant form of leukemia during the neonatal period and 80% of adult and only about 20% in children. While your ALL is the most common form of leukemia in children and it has equal sex incidence. However, T-cell ALL has male predominance. So AML is more common than ALL in the adult, and it represents worldwide approximately 10% of all cancers. However, it is the leading cause of death in adults less than 30 years old. Regardless of the forms of acute leukemia, the main pathogenesis is the bone marrow failure. As a result of the infiltration of the leukemic cells of the bone marrow, mature cells or functionally normal cells cannot be produced, leading to clinical manifestations of fatigue, malaise, pallor, bruising and bleeding secondary to thrombocytopenia, and severe infection as a result of granulocytopenia. The clinical features may also be secondary to organ infiltration. The preferential organs that are affected are, of course, the bone marrow, the spleen, the liver, the lymph nodes, because these are your hematopoietic organs. In case of acute lymphocytic leukemia, there may be secondary infiltration of the brain, leading to neurologic symptoms. In some forms of myeloid leukemia, especially those with monocytic component, there may be infiltration of the gingiva, resulting in gingival hyperplasia and oral lesions. So the illustration will show you some of the clinical features of acute leukemia. You could have skin infection in the form of pseudomonas, bleeding within the buccal cavity, and gingival hyperplasia. When you suspect a patient as having acute leukemia, the most important thing to do is to distinguish AML from ALL. And these are done by morphologic examination, use of cytochemical stain, immunologic markers, cytogenetic studies, and sometimes molecular genetic studies and the use of electron microscopy. The most widely used is the morphologic approach, although this is not really very accurate and subject to inter-observer variability. So here you must distinguish a myeloblast from lymphoblasts based on their characteristic morphologic features. So your myeloblast is a large cells, usually they are uniform in size, with finely dispersed chromatin material. The nucleoli is prominent, usually 1 to 4. The cytoplasm is abundant with fine granulation. Our rods are seen and is considered the most pathognomonic finding. And the rest of the blood cells will show dysplastic changes. While the lymphoblast may have variable size from small to medium, they have coarse chromatin material with absent or indistinct nucleoli. The cytoplasm is usually scant. Coarse granules may be present. Our rods is of course absent, while the rest of the myeloid cells, the red cell and the megakaryocytes, will not demonstrate dysplastic changes. Now, based on morphology, the French-American-British group has classified the acute lymphocytic leukemia into three morphologic groups: the L1, the L2, and the L3. The most characteristic of this is your L3, which shows cytoplasmic baculation. Your L3 is the leukemic equivalent of your Burkitt's lymphoma. The L2 may be quite difficult to distinguish from a myeloblast. Before, this morphologic classification were thought to have prognostic importance. For example, the L1, which is generally seen in children, has the best prognosis. The L2, common in adult, has poor prognosis. But the L3 has the worst prognosis, with patient presenting with bulky lymphadenopathy. The FAB also classified the acute myeloid leukemia into 8 categories, depending on the degree of maturation, from the undifferentiated to those type of AML that differentiate along megakaryocytic cell line. Now, these morphologic abnormalities are important because they may predict the occurrence of epigenetic phenomenon. For example, the M3 is your acute promyelocytic leukemia, and this may be characterized by the presence of disseminated intravascular coagulopathy. In addition, your M3 has the best prognosis among patients with AML. Now, the M4 and the M5, more specifically the M5, have monocytic component. So these types of cell may infiltrate the gums, and patients will present with gum hyperplasia. Your M6 has the same morphologic appearance as your myelodysplastic syndrome and even your megaloblastic anemia. The M7 is the most uncommon. It's characterized by the presence of cytoplasmic buddings. Another method of distinguishing myeloblasts from lymphoblasts is the use of cytochemical stains. Although this is now rarely used because of the advent of more accurate immunologic markers. Note that most of these cytochemical stains actually identifies the acute myeloid leukemia. The most commonly employed are your myeloperoxidase, your Sudan black, and your chloroacetate esterase. Today, we use the immunologic markers. So these immunologic markers, based on international agreement, are given nomenclature based on the cluster of differentiation. So differentiation, meaning to say some of these markers are expressed early in the maturation, some are expressed when the cells are already mature. Some markers will disappear, and some markers will appear later. So using these markers, we could more accurately distinguish the AML from the ALL. More importantly, these immunologic markers are able to distinguish the different types of lymphoid cells. So we could classify the acute lymphoid leukemias based on their immunologic markers as B cell, T cell, or rarely natural killer cell leukemias. These markers are generally used at the same time. Okay, there are no markers that are really specific. So you use a conglomeration of markers to distinguish AML, BALL, and T cell ALL. Now, the WHO has classified your acute myeloid leukemia into several categories. So you could refer to your textbook for the different subcategories underneath the major categories. So you have your AML with recurrent genetic abnormalities, AML with myelodysplasia related changes. So these are patients who started with myelodysplastic syndrome and converting to AML. Therapy related myeloid neoplasms. These are patients who develop hematologic neoplasm after being exposed to anti-cancer drugs. The AML not otherwise specified, the myeloid sarcoma, as well as the myeloid proliferation related to Down syndrome. So it's important to distinguish primary AML from secondary AML. So primary AML arises de novo, while secondary AML develop from other chronic marrow dysfunction. For example, aplastic anemia, paroxysmal nocturnal hemoglobinuria, patients with chronic myeloid leukemia transforming into acute leukemia. So these secondary AML are associated with distinct genetic markers and as a rule have different prognosis and often refractory to treatment. Treatment for your acute myeloid leukemia is generally intensive chemotherapy. So all the AML FAB subtypes are similarly treated except for the M3 variant, which is treated by adding your all-trans retinoic acid to the intensive chemotherapy. Intensive chemotherapy is combined with supportive treatment in the form of blood transfusion and control of infection. Since AML generally has a poor prognosis, patients should be offered stem cell transplantation once they are in complete remission. So this is a typical treatment regimen. The cytosine arabinoside is usually combined with an anthracycline, usually a daunorubicin, doxorubicin, or idarubicin. From this, you could add your thioguanine or etoposide, which is actually a very toxic drug. So once the patient achieves remission, you give another dose of chemotherapy in the form of consolidation. And if the patient is still in remission, you may have the option of offering stem cell transplantation, either allogeneic or autologous. For those patients who are not candidate for transplantation, you could give further consolidation therapy in the form of high-dose cytosine arabinoside, the use of mitosantrone, idarubicin, and your anti-CD33 antibody. Now, your acute promyelocytic leukemia, your M3 is unique because 95% of them will express the cytogenetic translocation between 15 to 17. For those patients who are negative for your translocation 15-17, you may be able to demonstrate the presence of the resulting chimeric gene, which is your PML RARA rearrangement. This is a fusion protein that has a reduced sensitivity to retinoic acid, preventing terminal differentiation of the malignant promyelocyte. Now, when you add all transretinoic therapy, there is acceleration of terminal differentiation of malignant promyelocyte to mature neutrophil so that the malignant cells die. And you achieve complete remission without bone marrow hypoplasia. APL is also associated with the highest overall survival of all adult AML. So if you only use standard chemotherapy without the ATRA, the complete remission rate is only about 70%, with 30% having disease-free period at 5 years. However, if you add ATRA to the chemotherapeutic agent, you can increase the complete remission rate to 80 to 95% in both previously untreated and relapsed patients, including the elderly. These are some of the prognostic factors in acute AML. So you have the cytogenetic. Some of them are favorable, some are unfavorable. Also, the time of remission is important. So if the patient have complete response at the first course of chemotherapy, the outcome is more favorable. Also, AIDS is a very important risk factor with those greater than 60 years old having the poor prognosis. The chronic leukemias are distinguished from acute leukemias by their slower progression and can be broadly subdivided into myeloid and lymphoid groups. CML is a clonal disorder of a hematopoietic stem cell. It accounts for 15% of leukemias. It has insidious onset and often accidentally discovered. It is characterized by the presence of Philadelphia chromosomes, and in the untreated state, the natural history is a transition from chronic to accelerated to blast crisis, mostly AML, but in some cases, ALL. The diagnosis of CML is rarely difficult and is assisted by the Philadelphia chromosome. This results from the translocation between chromosome 9 and 22, and as a result, part of oncogene ABL is moved to the BCR gene on chromosome 22. The resulting chimeric BCR-ABL has a constitutively active tyrosine kinase in excess of the normal ABL. The abnormal chromosome 22 is the abnormal Philadelphia chromosome. In most patients, the Philadelphia chromosome is seen by karyotypic examination of the neoplastic cells. But in a few, the Philadelphia abnormality cannot be seen under microscope, although the same molecular rearrangement is detectable by more sensitive techniques. CML occurs in either sex, most frequently the ages of 40 and 60 years. However, it may occur in children and neonates as well as in the very old. In up to 50% of cases, the diagnosis is made incidentally from a routine blood count. In those cases where the disease presents clinically, the following features may be seen: Symptoms related to hypermetabolism, splenomegaly, anemia, bleeding, symptoms of hyperuricemia that may lead to gout, and less commonly thrombotic or vaso-occlusive phenomena that may lead to visual disturbances and priapism. Laboratory findings would include leukocytosis, where all stages of granulocyte maturations are seen, eosinophilia and basophilia, and normocytic normochromic anemia. Thrombocytosis is common but sometimes normal or rarely low. The bone marrow would show hypercellularity with marked myeloid hyperplasia. Of course, the presence of the BCR-ABL gene fusion and the Philadelphia chromosome in 95% of cases. There is low leukocyte alkaline phosphatase score, although this test is no longer employed, as well as high vitamin B12, uric acid, LDH, and lysozyme. This picture shows you the peripheral blood smear of a patient with CML. And the picture on the left will show you the increase in buffy coat when the blood of CML patient is settled in a test tube. Attempts have been made to stage CML at presentation in order to predict prognosis. In the past, the most frequently used were the Sokal score, the Hansford, and the Uto score, which took into account factors such as age, blast percentage, spleen size, and platelet count. However, the rate of response to TKI is now a more useful measure of prognosis. Tyrosine kinase inhibitors, or TKIs, are the mainstay of treatment for CML, and several different drugs are now available. This includes your imatinib, nilotinib, dasatinib, and ponatinib. More newer drugs would include your bosutinib and your asciminib. First-line therapy for patients with CML is usually imatinib, nilotinib, or dasatinib. Most experience exists with inatinib, which is also the cheapest. Overall, around 60% of patients given imatinib achieve an excellent response and remain on the long-term therapy, whereas 40% proceed to a second-line agent due to intolerance or inadequate response. Nilotinib and dasatinib achieve more rapid responses as first-line therapy and are therefore used first in some centers, although the side effects are somewhat more common. They may also be used as second-line therapy after imatinib. Bosutinib is also an effective therapy, while ponatinib has the unique advantage that it is effective against CML that carries the T3151 mutation within the ABL. But ponatinib is associated with the highest risk of thrombotic events. Asciminib has a distinct pattern of binding to ABL kinase and may be useful either in combination with another TKI or in the event of resistance mediated by a mutation of the ABL kinase. TKIs are highly effective at reducing the number of neoplastic cells in the bone marrow and should be monitored by RT-PCR analysis for BCR-ABL transcript in the marrow or blood and or karyotypic analysis of the bone marrow, typically at 3, 6, and 12 months. Molecular response is assessed by the ratio of BCR-ABL transcript to ABL1 transcript, and it is expressed as BCR-ABL percentage on a log scale, where 10%, 1%, 0.1%, 0.01%, and 0.001% corresponds to a decrease of 1, 2, 3, 4, and 5 logs, respectively, below the standard baseline. A major goal of therapy is achievement of a major molecular response, defined as a 3-log reduction that is less than 0.01% or better. A complete cytogenetic response is defined as the absence of Philadelphia chromosome metaphases within the bone marrow. Treatment response can be defined as optimal or failure, with an intermediate area termed warning. Patients with optimal responses continue their original treatment, whereas those with treatment failure are treated with second-generation TKI therapy or stem cell transplantation. Patients in the warning zone should be maintained more regularly and might be considered for an early change in therapy or increase in the dose of first-line therapy. Patients who fail to achieve a BCR-ABL transcript level of less than 10%, normalized to the international standard, a 3-month time point so-called early molecular response have less favorable outlook. One mechanism of disease resistance to TKI is the selection for clones carrying mutation within the BCR-ABL fusion genes. For example, the T3151. This mutation may be detected by sequencing the ABL gene. The pattern of mutation can be useful in determining which treatment to choose as second-line therapy, since certain mutation confers specific resistance to one TKI while sensitivity to another TKIs persists. TKI therapy is highly effective, and after 5 years of treatment, the progression-free survival is 85 to 90%, with overall survival over 90%. For patient becoming BCR-ABL transcript negative, about 60% will remain negative on stopping TKI or remain in remission with a stable low level of the transcript. Hence, these patients are likely to be cured. For those who become BCR-ABL positive again after stopping with a rising level of transcript, treatment with the TKI will usually result in restoration of disease control. Additional forms of treatment for CML would include chemotherapy with hydroxyurea, which can control and maintain the white cell count in the chronic phase, but does not reduce the percentage of BCR-ABL positive cells. TKI have now largely replaced its use and that of alkylating agents such as busulfan. Interferon was formerly used after the white cell count had been controlled by your hydroxyurea, often in combination with your cytarabine. Again, this has now been replaced by imatinib and other TKI. It is still useful in pregnant patients. However, since TKI are not known to be safe in pregnancy and hydroxyurea is teratogenic. Allogeneic stem cell transplant is a potentially curative treatment for CML. But because of the risks associated with the procedure, it is usually reserved for TKI failures. The following algorithm may be used as a guide in the management of patients with chronic myeloid leukemia in chronic phase. Here, imatinib is suggested as the first-line therapy for many patients since it is inexpensive and the only agent now available in generic forms. The role of stem cell transplantation is diminishing as more TKIs become more available. Now, despite the availability of TKI, some patients will enter the accelerated phase of the disease and eventually terminate in blast transformation. Accelerated phase is characterized by anemia, thrombocytopenia, increase in blood basophils to 20%, marrow blast cells of about 10 to 19%. And eventually, this patient will terminate in acute leukemia, majority of which are AML, but some, about one-fifth, will terminate in ALL. The WHO classification system for hematopoietic tumors was recently revised, and the 2016 document recognizes myeloproliferative neoplasm as one of several myeloid malignancies. In routine clinical practice, MPNs refers to polycythemia vera, essential thrombocythemia, and primary myelofibrosis, the latter including prefibrotic primary myelofibrosis. These disorders are characterized by stem cell-derived clonal myeloproliferation with mutually exclusive JAK2, CALR, and MPL mutations. They also share common features that includes they originate from the hematopoietic stem cells. There is overproduction of one or more of the formed elements of the blood without significant dysplasia. They predominantly affect middle-aged and older age group. It is insidious, sometimes asymptomatic onset. The bone marrow is characterized by panhyperplasia, granulocytic, with or without monocytic elements. There is extramedullary hematopoiesis or myeloid metaplasia, primarily manifested in the spleen and less frequently in the liver. There is often secondary fibroblastic proliferation and reticulin collagen formation, resulting in myelofibrosis, either early or late as a complication of the disease. The bone marrow may demonstrate large number of megakaryocytes, sometimes atypical in appearance. There is evidence of platelet dysfunction, hence predisposing the patient to thrombosis and bleeding. There are cytogenetic abnormalities, although there is no specific cytogenetic abnormalities for each of these MPN. There seems to be transition occurring between these disorders such that they have overlapping manifestation, and they all carry some risk for terminating in acute leukemia. What is common to these three MPNs is the mutation that occurs in the JAK2. The JAK2 STAT signaling is mediated by cytokines and growth factors, including erythropoietin, thrombopoietin, which are essential for normal blood cell formation. Unchecked activation of your JAK-STAT pathway results in uncontrolled cell growth and survival, which could lead to pathologic state such as MPN. This increased activation of the JAK-STAT pathway can occur through activating mutation in JAK2 genes, exaggerated expression of cytokines that activate the JAK proteins, or through other mutation that disrupt the function of the molecules that turn off the JAK-STAT pathway. Hence, the JAK-STAT is constitutively activated. Mutation of your JAK2 occurs in the marrow and blood of almost all patients with polycythemia vera, in approximately 60% with essential thrombocytosis or primary myelofibrosis, showing the common etiology of these three disorders. Why the same mutation is associated with different myeloproliferative neoplasm is unclear, but depends partly on the dosage of the mutant allele, this being usually higher in polycythemia vera than in ET. Cooperating mutation and the cell differentiation state at which the mutation developed may also influence the phenotype. A minority of patients show a variant JAK2 mutation in exon 12 rather than the V617F mutation. In those patients with ET or PMF who do not demonstrate a JAK2 mutation, a mutation in CALR is observed in most cases. CALR is a multifunction protein involved in signal transduction and gene transcription. A mutation constitutively activating mutation in the MPL gene encoding thrombopoietin receptor are found in about 5% of ET and 10% of PMF. A mutation in one of these three genes is seen in 99% of PB, around 85 to 90% of cases of ET. There is a five-fold increased incidence of myeloproliferative neoplasm in close relatives of patients, implying a genetic predisposition to the disease. Polycythemia is defined as an increase in circulating red blood cells above normal. Other terms used is erythrocytosis. However, strictly speaking, this erythrocytosis refers to an isolated elevation in your red blood cells, while polycythemia refers to the increase in all blood cells, white cells, red cells, and platelets. We generally suspect polycythemia because of an elevated hemoglobin and hematocrit. However, one must distinguish between absolute polycythemia, where you have indeed an increase in red cell mass, from relative polycythemia. Relative polycythemia refers to a decrease in the plasma volume in relation to the red blood cells, while absolute polycythemia refers to a definite increase in your red cells, and this may be primary or secondary. Secondary causes of polycythemia are generally due to physiologically appropriate increase in erythropoietin. These are seen in most of hypoxemic state like chronic lung disease or chronic smoking. But it may also be due to acquired or autonomous erythropoietin production, as seen in patients with various malignancies and tumor, the so-called paraneoplastic syndrome. It could also be secondary to exogenous erythropoietin administration, commonly seen in long-distance runner, as well as secondary to post-renal transplant or the use of androgen and anabolic steroids. Rarely, your secondary polycythemia may be secondary to high affinity hemoglobin that leads to a decreased delivery by the red cell of oxygen to the tissues, stimulating more red blood cell production. In polycythemia vera, the increase in red cell mass is caused by a clonal malignancy of a marrow stem cell. The disease results from a somatic mutation of a single hematopoietic stem cell, which gives its progeny a proliferative advantage. JAK2 mutation is present in hematopoietic cells in about 95% of patients. And a mutation in exon 12, as we have mentioned, is seen in the remainder. Although the increase in red cell is diagnostic finding, in many patients there is also an overproduction of granulocytes and platelets. Some families have inherited predisposition to MPN, but JAK2 or ALCAR mutation are not present in the germline. Making the diagnosis of PB in a patient who presents with polycythemia can be difficult. Current criteria are shown in the slides. The identification of your JAK2 mutation has rationalized the approach to the diagnosis of polycythemia. A stepwise approach to the diagnosis is found in your textbook, Jamison's Harrison Principles of Medicine. In countries with limited resources, we may still use the criteria of the polycythemia study group, where they have category A and category B. So if you have category A, the major criteria, then you made a diagnosis of polycythemia vera. However, in the absence of splenomegaly, you need to have at least two of the minor criteria to make a diagnosis of polycythemia vera. The disease usually afflicts older person, and the main manifestation is plethora. And because of the increase in red cell mass, there will be hyperviscosity symptoms like headache, dizziness, etc. A characteristic feature is your pruritus that especially occurs after a hot bath, or what we term as aquagenic pruritus. Splenomegaly may be seen in 75% of cases. Some patients are predisposed to the development of thrombosis or thrombotic event, although some patients may also have hemorrhagic event. Hypertension, when present, is usually of the systolic type. Because of the hyperproliferation of cells, there will be increase in uric acid that may result in gouty attack. Peptic ulcer, usually explained by the presence of high basophils, are also common among patients with polycythemia vera. The main principles of therapy is to reduce the risk of thrombosis by normalizing your hematocrit to less than 45 or 42 in females. Most society would recommend the use of aspirin plus any one of the chemotherapy therapeutic agent when the disease becomes difficult to control. The median survival for those treated patients with polycythemia is 16 years. Thrombosis and hemorrhage are the major problems. Transition to myelofibrosis occurs as the late manifestation of the disease in 30% of cases, and 5% of them will develop acute leukemia. Essential thrombocythemia or thrombocytosis is characterized by sustained increase in the platelet count due to megakaryocyte proliferation and overproduction. The diagnosis is based on exclusion of other causes of chronic thrombocytosis. But now that specific genetic lesions have been identified, a positive diagnosis can be made in most cases. One condition that needs to be differentiated from essential thrombocythemia is your reactive thrombocytosis and your clonal thrombocytosis that is seen in other MPNs. Secondary causes of reactive thrombocytosis includes transient processes as well as sustained processes. The most common of these would be your iron deficiency anemia. In economically challenged countries, previous criteria for the diagnosis of ET may still be used. However, this criteria, the cutoff platelet count is 600,000 rather than 450,000 as set by the WHO. Again, it's a diagnosis by exclusion. You have to rule out reactive thrombocytosis, rule out chronic myeloid leukemia by a negative Philadelphia chromosome, and the hemoglobin must be no higher than 13 grams per deciliter to distinguish it from polycythemia vera. The peripheral blood film in essential thrombocythemia shows increased number of platelets and the presence of anucleated megakaryocytes. The bone marrow may show clusters of megakaryocytes. Most patients are asymptomatic, but some patients may have major thrombotic event or even hemorrhage when the platelet count is greater than 1,500. One characteristic complaint is your erythromelalgia, which is a burning sensation in hands and feet, often relieved by aspirin. About 50% of patients may manifest with splenomegaly. Treatment is primarily the use of aspirin, hydroxyurea in certain groups, as well as other forms of therapy. An algorithm for treatment is shown in these particular slides. Primary myelofibrosis is characterized by progressive generalized reactive fibrosis of the bone marrow in association with megakaryocyte atypia and proliferation, and with the development of hematopoiesis in the spleen, the liver, and liver. This is known as your myeloid metaplasia or your extramedullary hematopoiesis. Disease is characterized by the presence of splenomegaly, leukoerythroblastosis, teardrop poikilocytosis, marrow fibrosis with neoangiogenesis, and extramedullary hematopoiesis. Most patients are older. It has an insidious onset, but at the time of diagnosis, most patients will have anemia. Splenomegaly is the main physical finding, with symptoms resulting from massive splenomegaly includes abdominal discomfort, pain or indigestion, as well as early satiety. There's also accompanying hypermetabolic symptoms such as loss of weight, anorexia, fever, and night sweats. Bleeding problems, bone pain, or gout occurs in a minority of patients. Transformation to acute leukemia is seen in about 10 to 20% of cases. The laboratory will show anemia. The WBC are frequently high at the time of presentation, although late in the disease, pancytopenia may occur. The peripheral blood smear will show characteristic teardrop poikilocytes with leukoerythroblastic picture characterized by leukocytosis and the presence of nucleated RBC. The bone marrow is usually unobtainable by aspiration, and the trepine biopsy shows a fibrotic hypercellular marrow with increase in megakaryocytes, with presence of hyperplasia of abnormal megakaryocytes. The JAK2 kinase is mutated in approximately 50% of cases. There's high serum uric acid and LDH, which reflects the increased but largely ineffective turnover of hematopoietic cells. The 2016 revision of the WHO of hematopoietic tumors has divided your primary myelofibrosis into overtly fibrotic and the prefibrotic. The criteria for diagnosing the overtly fibrotic is shown in this slide. This is the prefibrotic. The treatment for PMF is usually palliative and aimed at reducing the effects of anemia and splenomegaly. Supportive therapy would include repeated blood transfusion, the use of folic acid and erythropoietin to improve the anemia. Hydroxyurea may partially relieve the splenomegaly, while other treatment, thalidomide, lenalidomide, azacitidine, and histone deacetylase inhibitors may be used. Ruxolitinib, splenectomy, and radiotherapy may often be recommended. The median survival is less than 5 years, and the usual cause of death includes heart failure, infection, and leukemic transformation.